Okay, good evening. We're here today to talk about COVID, estrogen and the immune system. My name is Margaret O'Hara and I'm a member of a group called the Long COVID Support Group, which is a Facebook group of people who have been suffering from COVID for a long number of weeks or months after the initial infection. For myself, I'm 4 months in, so I'm a bit of a veteran. And I'm joined here today by Leslie Mcniven, who's another sufferer like myself, Ron Daniels, who's the chair of the UK Sepsis Trust, and Louise Newson, who is a menopause specialist doctor. I'm going to ask them to introduce themselves, and then I'll come back and we'll talk a bit more about what we're going to be talking about and why we're here. Leslie, could you start?
Sure. Thanks, Margaret. So I found out about the support group on Facebook and joined several months into my COVID journey. And I must admit, I seem to be further along the line than the majority of people. So I think it's only fair to kind of help out and support people. I did actually do some campaigning for ME Action in the 90s when I struggled with ME and did recover. So I'm finding a lot of parallels between the lived experience of people with long COVID and people with ME, and trying to bring some of the lessons that we learned back in the 90s. And trying to ensure that everybody actually gets better and we don't have this hangover that we found with people with ME. So I'm here really just to be another voice and to find out a bit more from our experts who are joining us, because I think it is really interesting how there's lots of things overlapping and lots of relationships between different aspects of our bodies. So very interested to hear more.
Okay, thanks very much, Leslie. Louise, could you introduce yourself now?
Yeah, hi, I'm Dr. Louise Newson. I'm a GP and menopause specialist. So I've got a big background in hospital medicine and general practice, but I now run a menopause clinic, and I do a lot of research and education about the menopause, which will affect all women directly, and you could argue all men indirectly. But it's not just about symptoms. There are health risks with the menopause, because with the menopause there's long-term low hormone levels, and a lot of women become perimenopausal before their period stops. So sometimes for up to 10 years, hormone levels reduce. So I'm very interested in diseases such as heart disease, osteoporosis, diabetes, dementia, which will increase when we have low hormone levels. But with COVID, I've been very interested looking more into immunity, because as some of you might know, estrogen affects every single cell in our body. So it can affect our eyes, it can affect our bones, our hearts, but it also very importantly affects every cell of our immune system. So cells such as macrophages, neutrophils, have estrogen receptors on their surfaces. And estrogen has the ability to genetically reprogram these cells, improve the way they function, and actually increase their number. We know that men and women respond differently to infections, especially to viruses. So ever since the early data came out with COVID, I've been very interested looking and seeing that obviously men are more likely to succumb to COVID, and also more likely to have more severe disease, more likely to be in intensive care. And clearly, because all I do is think about the menopause, I've often thought, I wonder how much is associated. And there is some work from Wuhan that shows that women who have low estrogen levels are more likely to have more severe disease. So I've been doing some research with some groups at Liverpool University, at Oxford University, and also Prof. Tim Spector's symptom study tracking app to try and determine whether there is really a link. And some of the results from Tim's team have been very interesting. We've shown that women who are premenopausal, having regular periods, are less likely to have symptoms as those women who are menopausal. Women who take contraceptive pill, we found there's about 30,000 women had less severe symptoms as well. So a lot of the symptoms associated with some of the COVID patients and patients such as, or women such as yourselves who are having ongoing symptoms, are also menopausal symptoms, so it's very difficult to know. A lot of women think the menopause is just about flushes and sweats, but for a lot of women, because of the way estrogen affects so many systems of our body, symptoms such as muscle aches, joint pains, fatigue, headaches, dizziness, numbness, poor sleep, anxiety, all these symptoms can occur during the perimenopause and menopause. So I was very interested to be connected with your amazing group, because listening to some of the stories of women whose symptoms worsen before their periods, which is obviously the time when estrogen levels naturally decline, it just struck me that it's just too much of a coincidence. So it's very interesting to find out more, really.
Okay, thanks for that, Louise. Ron, do you want to introduce yourself and say a little bit about sepsis and the immune system, and what are the similarities? Mute. Knew that would happen.
Hello, I'm Ron. I'm the Chief Executive and founder of the UK Sepsis Trust. I also sit on the executive board of the Global Sepsis Alliance and on the WHO Technical Expert Task Force. So I've been immersed in sepsis for many years. Now, sepsis is the way the body responds to infection, and it can be triggered by any infection. Now, normally we think of sepsis as a consequence of bacterial infection, but we now know it can be caused by fungal infection, and indeed now by viral infection, including COVID-19. And we've just had a statement approved by the WHO saying that sepsis as a syndromic response to infection is the final common pathway to death from most infectious diseases worldwide, including during the COVID-19 pandemic and the recent Ebola outbreak. So there's a massive connection there. But my background and the reason I've got all this passion is because I'm an intensive care doctor. I'm just a jobbing district general hospital intensive care consultant. And therefore, over the last several months, particularly between March and May, I was immersed in COVID-19 and incredibly busy, as we've all been with this condition. And it just struck me that not only was COVID-19 causing sepsis, but also that the after effects of COVID-19 are likely to be almost identical, if not identical, to the after effects of sepsis. And that's why we're here this evening.
Okay, thanks for that. That was great, Louise and Ron. That gives a really good background. So I want to go to some of the questions which have come up, and this conversation has been initiated because a lot of the women in the group have been, talking about their periods going wrong, disappearing, coming early, late, heavy, light. They're just a bit perplexed about that. And some women who are in their 40s and 50s are talking about symptoms which they didn't have before, but actually are quite like perimenopausal symptoms. And it struck us that there might be some overlaps there, and it's important to sort of distinguish between them, but also to think about how that might be able to be treated. But something I wanted to also ask both of you about was, to what extent are changes in women's periods and hormone levels affected by any severe viral illness? I mean, so if anyone has had a severe illness like this that they're taking time to recover from, should we expect changes in our cycles? Would that normally happen?
Yeah, I'm not sure if you want me to answer. I think any insult to the body can affect periods. There's no doubt about it. And I'm sure Ron would agree. Younger women have regular periods. If they have sepsis, their periods can stop because it's their body's response. The body's not fit to conceive and to reproduce. So it's a shutdown mechanism. It's the same as if someone becomes very underweight or malnourished, periods will stop. So it's exactly the same. Our hormones are incredibly clever. And a lot of people think our hormones that regulate our periods just go around in one cycle and regulate our periods. But actually, of course, they don't. They interfere with our adrenaline, our noradrenaline, our stress hormones, if you like, but our thyroid hormones. There's all these amazing circles going on in our body with feedback as well. So anyone who's ill, regardless of what it is, can affect their periods. But also, it's really difficult because you don't know what's going to happen anyway. So a lot of women who have had COVID might be then developing perimenopause regardless of having COVID. And it's always easy. I mean, I see a lot of women in my clinic who are misdiagnosed with fibromyalgia, for example, because no one's found a diagnosis. Or we now got this thing called a diagnosis of medically unexplained symptoms, MUS, which was never there when I was a medical student. We used to keep going and going and going and going until we got a diagnosis. And so it's very easy sometimes, if we don't know as medics what's going on, we can say, well, let's give a label. And so I see a lot of women with fibromyalgia who actually have found that their symptoms have started when their periods started changing, and there was a cyclical nature. And then it became a lot worse when their periods had stopped. So replacing estrogen, giving them what they're missing, actually just improves their symptoms, and everything melts away. So then it's obvious what the cause is, but if it's not being thought of, then it's very difficult to know. And I'm not saying for 1 minute that estrogen is the underlying cause for COVID and the underlying treatment, but actually increasingly we know that estrogen is so important for our immune function. And sadly, as many of you know, women's health is neglected. Menopausal health is even worse. So there's so little research done. But we do know that women respond very differently to infections when they've got estrogen and they haven't got estrogen with them, as well as having all these symptoms that I've already discussed.
Okay, thanks. And do you think that, so for women in their 40s and 50s who have long COVID and are getting an array of symptoms, because that's one thing that we know from the long COVID groups, is just about any symptom can be attributed to long COVID. But for some of the women, there is a possibility maybe that could it be triggering perimenopausal symptoms? Could the illness have triggered it? Potentially, because a lot of women are saying they didn't have anything beforehand, and then since they've had COVID, they've got symptoms which are quite like menopause.
Absolutely, I don't see why they couldn't really, because they've had an illness. And you know, I see some people whose menopause or perimenopause is triggered by a shock, you know, a partner dying, a bereavement, something like that. And of course, we don't know what the timing of their symptoms would have been like if they hadn't had it. So absolutely, and I'm sure, I don't know, would you agree, Ron, that there's no reason why it wouldn't be associated?
No, I think that's absolutely right, Louise. And I agree with everything you've said. You know, that estrogen is not the panacea for COVID-19, but if there are certain sectors of the population in which we identify a sector-specific solution, we should pursue that. And I think it's entirely logical that COVID-19, as you say, just like any critical illness, can cause a perimenopausal or a premenopausal syndrome, because of course any critical illness is a catabolic process, and as we begin to recover from that, we need to build it as an anabolic process. And in simple terms, catabolic means we're breaking down protein in the body, anabolic means we need to build back up protein. So it's natural after any critical illness that our bodies are craving a high calorie, high protein diet. The body's natural response is to shut down non-vital functions, and that will include, of course, the normal menstrual cycle. So I think that's absolutely right. I think we also have to consider whether these effects might be more marked in perhaps women who are undertaking ultra low fat diets, because of course, as we know, fatty acids, cholesterol are essential for the production of sex hormones. And I wonder whether there's something there as well to explore.
Okay, thanks. Some women have said, some women who normally have regular periods have noted that their long COVID symptoms seem to be cyclical and seem to be worse just before their period. So that's when, if I'm correct, estradiol is lowest. Do you think there's any benefit, and where we might see that there would be a benefit for perimenopausal or menopausal women to have estrogen replaced? Is that also the case for women who are having normal, you know, younger women who normally would be having normal periods?
Yeah, it's very difficult because a lot of women I see in my clinic are still having periods, and actually increasingly I see people who are starting to have symptoms and their periods haven't really changed much, but when you really quiz them, their periods might have changed in nature, not just frequency. So the diagnosis of a perimenopause is not a biochemical blood test. You can't do a blood test, because if I did a blood test on a woman in 3 different days, I would get 3 different results. So the guidelines are very clear. For a woman's over 45 and has symptoms suggestive of the menopause, and their periods have changed in nature or frequency, you can essentially diagnose. Between 40 and 45, blood tests might help, but often they're still unhelpful because of the fluctuating level of hormones. Under 40, the recommendations are we should do blood tests, but again, they're very unreliable, and we usually go by symptoms. So for if someone's wondering about the symptoms, they're as long as your arm. But if you go to my menopausedoctor.co.uk website and put in questionnaire, there's some symptoms that you can look at. And if these have come on over the last few months or years and your periods have changed in nature or frequency, then actually number one diagnosis would be perimenopause. And we know that obviously our hormones are fluctuating all the time when we're having periods, but just before the periods is when our estrogen levels are at their lowest. And so it's very interesting that these symptoms are worsening. And as a lot of you might know, HRT is actually very safe. So it's only 3 letters. There are different types, there are different doses. But for the majority of women, the benefits outweigh the risks, because not only does it improve symptoms, it actually has long-term health benefits. So I've mentioned the risks such as heart disease, diabetes, osteoporosis, dementia. The risk of these conditions reduces with HRT. So there are lots of reasons actually why women should take HRT, but also perimenopausal, because you want to replace the estrogen as soon as it starts going, because of things like osteoporosis. Bone turnover really rapidly increases during the perimenopause. So it's a very, very interesting time, I think, to know for a lot of women who are suffering, what are the risks of them trying a low dose of HRT? And we know, and Ron will know far more than me about the clot risk with people with COVID. And so certainly having oral estrogen or the synthetic contraceptive pill, I think wouldn't be a good idea, because there is a small risk of clot. For most women who are fit and well, this small risk is still a small risk when it's increased. But if there is this risk with COVID that we're seeing with clots, then the only way really to have estrogen would be through the skin as a patch or gel, and now we've got a spray. So it goes through the skin into the bloodstream, it bypasses the liver that produces our clotting factors, so there's no increased risk of clots. So actually it's very safe for most women.
And somebody had asked if, so talking about contraceptive pill, if this is somebody whose periods have now become irregular, whether it would be worth taking the contraceptive pill full time to just not have a period during this, while they're suffering from long COVID and they're trying to get their body back on track, whether it might be beneficial just to take the pill to kind of smooth it all out.
Yeah, and I think that is a really good idea for a lot of people, and certainly for all sorts of reasons now we recommend that the pill should be taken back to back, so without a week's break, because there's no reason. It's just a historical reason. As a lot of you know, the period that women have with their week break is a withdrawal bleed, because they're not having the hormones as opposed to a proper period. So we don't have to have periods. The only thing I would say is about the risk of clot, and I don't know whether Ron would say something about that. If someone is known to have COVID, I think there's so much we still don't know. I, as a physician, would be a lot happier someone having transdermal estrogen, and young women can still have it. It's a treatment for PMS as well, rather than starting the contraceptive pill, which has synthetic progestogen in, and it's oral with a risk of clot, and it's got synthetic progestogens in, and progestogens have a risk of clot too. What do you think, Ron?
Yeah, no, I think that's absolutely right, Louise. I mean, you know, we've all seen very rare, horrific stories of young women who've been started usually on the combined pill rather than the mini pill, who haven't been adequately counselled of the risks, who have succumbed to a massive pulmonary embolism. And it's heartbreaking and it's horrific. COVID is a procoagulant condition, so it's very likely to cause blood clots. And indeed, in people who've suddenly died from COVID, it's been one of 2 mechanisms. It's either been that they've developed sepsis and multi-organ failure, or it's been that they've developed massive blood clots. So I think that's absolutely right. We'd have to be really cautious in promoting the use of the combined pill, of synthetic sex hormones in women who are acutely ill with COVID-19. But that's very different to the after picture, and there the risk of procoagulation, the blood clot formation, is very much lower, and we need to think very carefully. We need to build evidence, and we need to understand what can help women.
And do you think you could have see your doctor, and can you have your blood checked for whether it's likely to clot and whether it would be safe to take extra hormones?
Well, I mean, again, I'd value Louise's opinion on this, but in essence, the tests that we have that measure blood clotting are pretty poor. And you can have normal blood tests for clotting, but still have a tendency to clot. And the reality is that there isn't a single test we can do to say you're not at risk of developing a DVT or a PE.
No, I totally agree with that, and I think the clotting blood tests, there are so many. Certainly when Ron and I qualified and graduated, there weren't many, and there's more and more tests. And having a raised test or a positive test doesn't mean you're going to have a clot, and lots of people will have a negative test and still have a risk of clot. So for me, if we're trying to answer this estrogen question, it would be a lot safer to give people estrogen through the skin for a 3-month trial. And actually, if a woman is still having her periods, then she doesn't have to have a progesterone anyway because she's producing it herself. If a woman is not having her periods regularly or having less than 4 periods a year, then now we give the micronized progesterone, which is a body identical progesterone, so the same structures we produce ourselves, and there's no risk of clot with it as well. So a lot of people, and I used to think it, that the HRT is for menopausal women and everyone younger should have the contraceptive pill. But actually, there's so much more evidence to support HRT. And because it's so safe through the skin as estrogen, you know, the risks of giving HRT to a young woman for 3 months to see if it helps, because all you're doing is topping up their estrogen levels. I can't actually think of any risks. Everyone worries about the breast cancer risk. If a woman is under 51 and has some estrogen in the form of HRT, there's no increased risk of breast cancer because you're just topping up the natural hormones. The dose in estrogen, for example, in a patch or the pump of estrogen gel is a lot lower than the dose that people would get as a contraceptive pill. So it's actually one of the lowest risk prescriptions that I've ever written in my whole medical career is HRT, especially for young women.
That's really reassuring to hear, because I'm self-experimenting with a little bit of extra estrogen at the moment. I've been on HRT for about 18 months and I use the patch, but I have the gel, which is the gel that you rub into your skin. And I've been experimenting over the past few weeks with that because I've been feeling as though I feel a bit better when I'm using it. And if I forget to put it on, a couple of days later I end up really tired. So I'm personally finding it quite useful. And we hear anecdotally from some other of the women that they are finding it quite useful. And I feel as if I'm, like Ron says, I'm in this state of trying to recover from this illness. And I think it's just a little boost that I need, along with all the other things that I'm doing. And Leslie, you wanted to talk about holistic treatments and...
Yeah, I think this is really speaking to something we were chatting about before we came online. And I agree, I think we had a useful chat in an admin group meeting to when we started realising we had a lot of experience of HRT in the room, and that was quite a light bulb moment when we realised there was clearly a link there. So as a GP, Louise, and as someone who clearly has a very high level view of the whole medical system, Ron, I'm just really wondering how on earth the NHS can respond to this type of illness when the way we structure our healthcare is very specialised. And what I'm hearing both of you saying is that because this illness impacts on different systems within our body, it doesn't just confine itself to one specialism. So how can we take this holistic approach to support patients that's very much based on, well, you're a 35-year-old woman, you might benefit from this. You're a 55-year-old woman, you would maybe benefit from this. So it's not even about gender. And we know that, again, we tend to not even be that great at focusing on gender differences between men and women in medicine historically. So I think this is a real challenge for healthcare, similar to what I saw in the 90s with ME. And because medicine takes time to respond, a lot of people went down the complementary route and looked to try and kind of self-manage and take a holistic approach, which I think in many cases was beneficial. And I credit my recovery from ME, when I still know people who didn't recover from ME, to extreme rest, being cared for by my parents, because I was a young person at the time, and changing my diet quite significantly. And I'm empathetic with people who want to try things, but there needs to be scaffolding, there needs to be support from GPs. So how can sufferers best get equipped to self-manage, but also to find the right people to speak to? So I think the group is doing a tremendous job in finding people like yourselves to speak to. But what else could we be doing? I guess I would love to ask you.
Well, Louise, shall I take that first from a general perspective, and then you pick up?
Yeah, absolutely.
Yeah, and obviously you'll have a lot of expertise in the general perspective. I mean, you know, after any critical illness, there are really three main domains of after effects, and they persist for months and months and months. And we see this in people who've survived sepsis. We tend to say as a charity, you're likely to be back to around 90% of your normal self within 12 to 18 months. Don't have higher expectations than that. But the three domains really are the physical domain, which will include fatigue, will include pain syndromes, will include things as seemingly trivial as brittle hair and nails and loose teeth and so forth. There's then the cognitive after effects, which will include this brain fog, will include poor judgment, poor concentration. And then there's the psychological after effects, and they're likely to be enormously enhanced during people recovering from COVID-19, simply because the fear at outset was so great. And so the pre-existing anxiety is going to fuel any after effects in terms of the psychological state. Now, in terms of recovery, yes, this is physical, this is nutritional, but it's also about brain space. It's also about mindfulness. Now, I think, to my mind, the best evidence around complementary therapies exists in the acupuncture space, but anything that's going to help people to get into a good brain space, to improve their mental health, to settle their background level of anxiety, whether it's Reiki, whether it's Hopi, whatever it is almost certain to be able to help the cognitive and psychological effects, and will probably assist in the physical effects. So I think this is multifactorial. I think there's multiple areas of need. I think there's absolutely an urgent need for proper rehabilitation, which needs physiotherapy, perhaps occupational therapy, cognitive behavioral therapy, neuropsychiatric assessment, and all of these domains. But I think if complementary therapy can help that, and I think there is some perhaps not hard evidence, but certainly some reasonable soft evidence that it can help, then why not?
Excellent, good. That's really useful, because I'm doing an interview in Scotland next week, and I'm going to be quoting you on some of that, if that's okay. Because I think that's the kind of reassuring message that we can put out, that there are things you can do for yourself that are probably not going to harm you, but be careful and avoid snake oil salesman whilst you're at it. And I think the group has been really good for helping people see what's worked for them, but without necessarily saying this is going to work for you. And just to
I think, if I may, and sorry, I need to let Louise respond as well, but I think if the biggest advice I can give to anyone who's survived this or any other critical illness is just be honest about your symptoms, because everyone around you, your loved ones, your employers, will be expecting you to bounce back to normal. And it's about talking. It's about acknowledging you're not yet back to normal. You're not your normal self. You can't do this, and you need their help. You need them to buy into your recovery as well as you buying into your recovery.
Excellent point. And culturally, we're sometimes conditioned to push through, and this is not going to help us in this instance at all. Louise, I'd love to hear from you a bit more about that.
Yeah, I think the whole narrative is really interesting. So certainly when I was at medical school, I'm sure Ron was the same. It's very paternalistic medicine that we were taught, really, and now it's it's changed so much, quite rightly so. And a lot of it is about sharing decision making with our patients and individualizing care. And that's not just the work I do as a menopause specialist. Everybody needs individualized care, and so we should be looking really holistically. And it's not just about, do they need a hormone, for example? It's like, well, let's look at their nutrition, let's look at their exercise, let's look at their stress, look at their sleep, what else is happening. But sometimes you can't see for the wood for the trees. So it's really important for people to, and a lot of women know, I mean, Margaret quite rightly was saying, well, she feels she needs more estrogen. So she has quite right, and women and men often know within what feels right. You know, when you're eating McDonald's, it's not the best thing for you. So it's really important actually to look at the whole person. And then it's very difficult, like you were saying, Leslie, to actually get help because, you know, I get incredibly frustrated, and I won't tell you how frustrated I am about how poor menopause and perimenopause care is, because there's no funding. I have to do my work privately because there's no funding in the NHS for good quality menopause care, which is outrageous when it affects all women. But women have to become empowered about this, and certainly, you know, anybody who has a long-term condition, I really feel they need to work and listen and take advice from evidence-based, because that's what's so important. And some things we don't have evidence for, but as long as it's safe. So, for example, Ron saying acupuncture, absolutely, but not going to buy a whole bag full of supplements because they've been sold to you, or you've read them through some sort of dodgy article online. So it's looking at the benefits that you're getting, and some things it's looking at short-term benefit for symptom control, some things it's longer-term benefit as well. And it's also, I think, if something doesn't feel right, then it probably isn't right. And if a doctor or a healthcare professional is telling you something that doesn't quite feel right, then we need to take a step back and think about why it doesn't feel right, try and get some more information. And sometimes we do go and see another healthcare professional, and that's fine as well. As doctors, we're not God, we don't know everything. And I feel very frustrated in my clinic when I see and listen to women who have suffered for many years because they haven't been given the right advice and treatment. And most healthcare professionals haven't had any menopause education. So if you went to many doctors and said, look, I'd like to try some estrogen gel for 3 months to see how I feel, they'd probably look at you and say, no, that's going to give you breast cancer. However, we know that women who have estrogen on its own actually have a 25% lower risk of breast cancer, and also a lower risk of mortality, death from breast cancer. So it's actually really safe. And so a lot of reason people get refused is because of misunderstanding and miseducation. So I think it's really important that as patients, if you like, we try and understand what we need and what would be best and what's safe as well, but looking at it in a very holistic way, and individualized as well, I think is so important.
Brilliant, thank you.
Great. So thanks for that. I think these are wise words. And if people wanted to get some more information about that, Louise, you have a website, don't you?
Yeah, so I've got a website called menopausedoctor.co.uk, which is evidence-based and unbiased information on it. There's under the resources section, I've got some booklets, leaflets. I do a weekly podcast as well, and there's lots of videos as well. We've also just launched an app called Balance, which is a free app for women, again, to provide evidence-based and unbiased information. And people can track symptoms as well. So you could track your symptoms and also track your periods as well. So that can really give people a feel for how they're changing. And so that I think it would be very powerful to see how your symptoms are, how you're feeling. You can even track your symptoms various times of the day as well, and also you can track what you've eaten, how your sleep is, whether you've done exercise, meditation, whatever. So that's an easy way of trying to collect everything together, and it also creates a health report. So you can download this information and on an easy PDF that you can share with your doctor. Because a lot of the work I'm trying to do is to try and make it easier for the consultation and your doctor. So that might be something to have as a starting point if you think some of your symptoms might be related to your hormones.
Thanks. And Ron, the UK Sepsis Trust has a fantastic website, and Ron's been doing some videos with us in the long COVID group to try and explain some of the symptoms that people are having. So I would really absolutely recommend everybody to go to that. What's the URL for the website, Ron?
Thank you. So the website is at sepsistrust.org, and there you'll find a lot of general information. We've got a couple of booklets actually that we've produced. They're good quality booklets. We produced them in response to the COVID campaign, so they've been produced in haste, around what it feels like to recover from a critical illness and what after effects you might expect. as well as some advice on your rights as well as employers' rights when you return to work, because I think it's important to recognise that people aren't going to bounce back into society as they previously have done. So those are available on the website. There's a lot of background information there. And I think it is important that people who've survived COVID, because their immune systems are going to be in disarray for some months or years afterwards, to equip themselves with the knowledge as to what to look out for in terms of sepsis, if they have, particularly women, a water infection, pneumonia, something like that, to know the symptoms to look out for and when to seek help. In terms of the videos we've been doing at the moment, they're sitting on the Sepsis Trust YouTube channel. So if you just look at the UK Sepsis Trust YouTube channel, they're there. We're building a big library. And I think we all agree that what's important is that we have a proper portal in the future for those resources. At the moment, they're answers to frequently asked questions. So they're very informational. But in the near future, what we significantly hope, with resource coming in to be able to fund this, is that we can provide proper self-directed rehabilitation resources to complement those that are, we hope, going to be provided by NHS England and Improvement.
Okay, thanks very much for that. And you mentioned there about immune systems being potentially in disarray going on, and we know that winter's coming up. So I understand that people who've had sepsis are then at higher risk of having other infections and from having complications from those. And that brings me back to the estrogen as well. And I'm just wondering, because estrogen is such an important molecule for the immune system, whether that might be even for women who are maybe not having problems with their cycle, but maybe just to think about, because maybe that will be protective for the post-COVID period if their immune systems aren't quite working as they should. And also something that struck me was, what about men? Because men do produce estrogen, don't they? I mean, in smaller amounts, obviously, than women. But do you think they might be suffering and they might find a benefit for their immune systems?
Well, I mean, in the estrogen side of things, this is Louise's area of expertise, but absolutely we need more work in these areas. But from the perspective of what happens after sepsis and what we fear might happen after COVID, the immune system goes into a state of, if you like, paresis. It's paralyzed. And for up to 7 years after an index episode, people with sepsis are at increased risk of repeated infection. Now, there have been no convincing data internationally to say people can catch COVID for a second time. And equally, there's been no convincing evidence that people can carry dormant COVID viruses or SARS-CoV-2 viruses and they can reawaken. We need to watch out for that, but at the moment, that seemed to be a low risk. But what we know in people who've had sepsis is that they contract other infections. And we're concerned that in the population who've had COVID-19, the risk of their immune system misreacting to a bacterial infection, and commonly sepsis is caused by pneumonia, by water infections, or even by something as simple as a cut or a bite or a sting, that they could be at increased risk. And so I think it's really important that we educate the post-COVID public that they need to be aware of what to look for and when to seek help. But I absolutely bow to Louise on the estrogen question. I do welcome that you see it as equally important in men, perhaps not quite as equally important as in men.
Of course, men are very important, but it's very interesting. So we all naturally produce estrogen, and men do produce estrogen. Women produce testosterone. In fact, women produce more testosterone than estrogen. The estrogen that men produce and also some women produce is actually a different type of estrogen from fat cells, and it's called estrone, so it's quite a weak type of estrogen, and it doesn't seem to stimulate the immune system the same way. So, for example, people who are overweight are more likely to have diabetes and heart disease, and the estrone is probably more of a pro-inflammatory sort of the cells respond in a pro-inflammatory way, whereas estradiol, which is what we produce when we're menstruating, when we're having our periods, and when we replace it with natural HRT, is estradiol, so it has a anti-inflammatory response, and it works, as I've already said, on our immune system. What we don't know is the role of testosterone, and we're doing some work in Liverpool to see whether men who have testosterone, if they have low levels, are they more likely to have a more severe disease? Because we know that men, for example, who have cardiovascular disease, who are obese, who have diabetes, are more likely to have more severe disease, and these men are more likely to have low testosterone levels. It's a bit more complicated in men, and we don't know, because there are also some drugs that block the actual testosterone in men, and that we use, for example, for men who have enlarged prostate glands. And some data, although it's small numbers, show that those men are a bit protected. So the jury's still out with testosterone in men. I mean, what we do know, and I know Ron agrees, is that people, as in men and women, are more likely to have more severe disease and more likely to die from COVID if they're overweight, have diabetes, or cardiovascular disease. So we really, all of us, whether we've had COVID before or not, need to look at ways of improving our lifestyle. And I know I talk about menopause a lot, but that's all I do at the moment. We know that if menopausal women are given the right dose and type of HRT and the right type of holistic advice and management, they have a lower future risk of heart disease, diabetes, obesity. So this again is why I'm doing some work with NHS England, because what I want to do is try and show that women can be healthier and more protected, more feel safer going back to work, for instance, or going on a tube or a train, because their immunity is better, but they're also, if they are to get COVID, because a lot of us will get it, they're not going to have an overwhelming infection or have long-term problems, because their immune system is that much better and well primed. And some of the questions we don't know the answers, but we hopefully will have some answers in the next few months. But I mean, I think this session really is to say there are many things we don't know, but there are many things about hormones that are not being addressed. And for a lot of women, the only women really who shouldn't take HRT in the first line are women who've had an estrogen receptor positive cancer. It's usually a breast cancer. So first line, those women wouldn't have estrogen, but actually some women still have it. But everyone else really can consider a low dose of estrogen. And, you know, it would be lovely if I heard from some of the group that they had tried some and it had helped, or whether we could do a study to really see, because it's such low risk. And it's also very cheap. It costs the NHS about £4 a month. So it's very cheap way of trying to see if people can improve.
Yeah, I think that's a great idea to do some studies on it, and we have a very large group. I think it's around 15,000. I haven't checked today, but I mean it's around 15,000 people, actually the majority of whom are women. And we don't think that's because more women have long COVID, but I think possibly it's just because it's on a Facebook group and women are more likely to seek help on a social media platform, more so than they get. Although that's another question.
Well, you know what I'm going to say, don't you? I'm sure it's not a coincidence, because otherwise these women will be getting their partners on there. So I think it would be very interesting, and you'd know the answer within 3 months, because estrogen works very quickly. It's used every day, so it doesn't build up in the system. So if someone has estrogen in a pump, the gel, for example, today, it's worn out of their body tomorrow. So it's very, very safe. And in fact, actually in Stony Brook in New York, they're doing a trial giving estrogen patches to men and women to see if it will reduce the severity of COVID. So people who are presenting to us with symptoms suggestive of COVID, they're giving them an estrogen patch to see if it will damp down the acute response, because we know estrogen affects the cells of the acute response and the long term, so the innate and adaptive immunity. All those cells are responsive to estrogen.
Okay, well, I think that's something for Leslie and I to take back to the group and have a chat with them about. But I'd say you get quite a few takers, judging by the responses to some headlines that have been going.
If I may, Margaret, and Louise has already said this, you know, this may well help a lot of people, and I agree that it is a safe therapy and of potential benefit. But I think Louise and I agree, we're not going to find a single magic bullet to fix this problem. You know, you can't take zinc or take selenium or take estrogen in isolation. This is absolutely about the holistic picture. We've got to fix nutrition, we've got to fix attitudes, we've got to fix mental health, we've got to fix all of these things. We've got to understand that, you know, you're not going to be doing couch to 5K. This is not about graded exercise. This is about listening to your body. This is about holistic recovery. And if estrogen can help that, fantastic, and it may well do, but it's only a part of the solution.
Mm-hmm. Okay, so on that note, I think that's a great place to end, unless Leslie's got any other questions.
I don't think I do. I think I've just found this conversation fascinating, and I agree with what you're saying, Ron, about the need to have a holistic approach, but equally, from what Louise is saying, it sounds like we've neglected various aspects of women's medical research hitherto. And actually, one of the things that could be an effective treatment could be in that area that's not currently being researched as well as it could have been. So it feels like a quick win to kind of put some money, some time, some interest into areas of possibility in the short term, whilst also agreeing about having a kind of personal responsibility. I mean, my last reflection is just purely, when you're ill, you just want to know there's something you can be doing to help yourself. And so the worst thing you can be told is, oh, everything's negative, go home and get better. So if there are any possibilities that something might help, being able to go to your GP armed with some ideas to say, oh, Dr. Louise Newson, have you heard of her? So anything you can produce, Louise, I love the sound of that app, and I'm totally going to be all over that after this session to see what that's all about. I think if you can encourage doctors to take on board what you're saying and be open to patients coming in and wanting to discuss that, because I think you're right, there's a massive miscommunication. As someone who was on HRT for 18 months before I got ill, it could have been a factor in the fact that I recovered relatively quickly in comparison to many other people. And I think I would agree with you, Ron, about diet. And there's a lot of evidence about low-fat diets being inherently unhealthy, and correcting the misapprehension um, fat being bad for us. We're actually eating protein and fat in healthy quantities and through healthy sources. There's a huge amount of people now using keto diet and low-carb diets for various illnesses with interesting results. So I think the more we can have these cross specialist conversations, I think the better, to see how things overlap, and we can support each other to try and take forward the messaging that these are things that patients can do to help themselves, and things that the medical profession can pick up, hopefully to help, because the amount of people, 15,000 in this group, who are desperate to get well, you know, we need to be rebuilding our people as well as the economy. Sorry, I don't want to start getting political now, but there is a real danger that people who are ill but not dying are being overlooked, as I'm sure you're all aware. And so we can't afford to have a chronically ill population that we're having to support, irrespective of the human cost of that as well. Thank you so much for all your support, for everything you're doing, Margaret especially, because you're always the person who organises everyone else. And we want to say thank you to you for everything.
Your Wi-Fi's giving up the ghost there, Leslie.
But also for your experts like Dr. Ron and Dr. Louise. It's much appreciated. Thank you.
No, not at all. And Margaret, if I may, just from my side, my kind of closing remarks really.
Sorry, I realised that when I was saying things and your reactions were out.
Not at all. Not at all. I would just say, you know, don't underestimate the power of this group that is growing rapidly, because there will be, I'm afraid there will be skeptics out there among the health professionals who don't believe that the long tail is genuine, who aren't able to rationalize and understand that there might be after effects. We've seen that in people who've survived sepsis. We've seen that in many other conditions. The power of this group is huge. But again, just to offer a bit of hope, the learning we've had from people who've survived sepsis, that typically the journey is around 12 to 18 months to recover to about 90% of your previous self. And some people never recover to exactly their previous self, but a lot of people actually find that even though they might be less physically or cognitively able, they're actually a better person for the journey.
Okay. So thanks very much for that, and thanks Ron and Louise, because you're giving your time for free, and this isn't the only thing you've done for us, and we really, really appreciate it. And I would really urge people to go to the websites, the Sepsis Trust website and Menopause Doctor, to get some more information about that. And I think we will have a discussion in the group about maybe tapping into the hive mind that we are, and seeing what we can find, maybe asking some research questions to try and answer some of the questions that you have. But thanks ever so much for joining us this evening, and for agreeing to be recorded and your words sent out into the world. And if we can help you in any way to get your messages across, then please do contact us. I think you're right, Ron. I think we are turning into a powerful group. And I think Leslie was right also when she said that maybe this is a moment for forgotten groups like ME and post-sepsis and menopausal women to sort of come together and say, well, actually, hold on a minute. You know, this is the point at which we say, let's not ignore chronically ill people anymore, or people who can be helped.
Absolutely. I think there's always help for everyone, and it's just tapping into the right. But I think certainly if there's any way of being able to be involved in some research, it would just be incredible, because it would not only help your group, but it would help other people as well. Whether we get good results or negative results or no results, it's still actually every bit of research is going in the right direction. So I am not a researcher, I am involved in research, but there must be people out there who could really help to drive this forward. So because it's actually very easy study, very cheap, doesn't need lots of investigations or fancy tests. So it'd be very interesting to hear, what comes out of this discussion today. So thank you for inviting me.
You're very welcome. Thanks for your time. Thank you, Ron. And thanks to Leslie also for joining us. And maybe we'll see you again on a future video.